Okay, our next speaker is Dr. Gary Monteiro. Dr. Monteiro is trained in both pediatric and adult CV anesthesia, and he is going to talk to us about non-cardiac surgery and endocarditis prophylaxis.
I was sitting there listening to your lecture, having nightmares because I've been called in to take care of all 4 of those patients in labor. Not at the same time, but different patients. So I'm going to talk to everyone today about non-cardiac surgery and endocarditis prophylaxis. And this is the simple question when I go to my dentist, when I go to have my colonoscopy, when I go to have surgery, do I need to have antibiotics associated with that surgery? If it's a major surgery, orthopedic, ENT, this kind of stuff, you will most likely have prophylactic antibiotics. Green button. Okay, so I have no disclosures. When we talk about endocarditis, this is what we're talking about. This is a picture of a mitral valve here that's been cut out, and you can see there's something sort of weird on it. It's bumpy, there's bruising or hyperemia around it, and this is a mitral valve vegetation. So I'm basically going to discuss the latest guidelines for antibiotic prophylaxis in non-cardiac surgery for the adult congenital heart disease patient. Cardiac surgery patients are going to receive prophylactic antibiotics. So there are 2 sets of guidelines which address this in the general sense, and one's the guidelines on preventing endocarditis. The other is the 2008 guidelines, which we keep referring to today on the management of adults with congenital heart disease. And underneath is just another version of endocarditis so everyone can know exactly what endocarditis looks like. So just in review, when we're talking about infective endocarditis, there's a couple of events that have to sort of happen leading up to endocarditis. The first thing is we talk about forming non-bacterial endocarditis. What this means is that usually the blood in your vessels is laminar, meaning it flows in straight lines. But when there's some sort of rocks in the river, it forms eddies. The blood flow swirls a little bit. And what this does is it forms little areas of low pressure, little areas of high pressure. You start to lay down a little bit of platelets. You start to lay down a little bit of fibrin, just based on the non-laminar turbulent flow. The next event that happens is somehow bacteria gets into your bloodstream. This happens fairly often. We'll talk about how this happens. But the bacteria gets into your bloodstream, it's floating around, and it finds those little eddies. It finds those little areas of low pressure, and it decides to stick there. And then the final thing that happens is it decides it likes where it's stuck, and it decides to grow. So the most common bacteria that does this is Strep viridans, and this is a greater than 50% of the endocarditis we see that's not associated with IV drug use. I came to Houston from Seattle, so we were seeing lots of weird bugs because there's a lot of IV drug use in Seattle. But for the most part, we see Strep viridans, which is just part of the normal bacteria that live in your mouth. That's usually where this is coming from, just, when you have your teeth pulled, you have a tooth extraction, you see that transient bacteremia, depending on which paper you look at, 10% to 100% of the time. When you brush your teeth twice a day, you see transient bacteria 20 to 70% of the time. So this is happening to you all the time, right? Assuming everybody brushes their teeth. But I put up some bad examples of teeth there. But every time we brush our teeth, you might scratch your gums in between your teeth, you get a transient bacteremia. And over the course of 1 year, you're more likely to have a bacteremic event 5.6 million times more likely when you brush your teeth than from getting a single tooth pulled. So throughout history, since 1955, there have been multiple versions of who needs antibiotics, what antibiotics do we need. This is sort of a hot topic that gets addressed every couple of years. You can see it used to just be penicillin, and then going through to ampicillin. So there's been many versions of this, and I'm going to go over the most recent ones with y'all, or you all. Okay, so they were updated in 2007, and the rationale to update these guidelines were that endocarditis is much more frequently to result from the random things you do every day than from the bacteremia associated with dental procedures, GI procedures like colonoscopy, the routine screening colonoscopies, or GU, which is cystoscopies and stuff like that. Prophylaxis itself prevents an exceedingly small number of infective endocarditis, if any, if it has any validity in dental, GI, and GU procedures. And then the risk associated with taking antibiotics typically outweighs the benefit, except in high-risk populations. So what are high-risk populations would be the next logical thing there. So they're delineated in this chart, and this is from the Infective Endocarditis Guidelines, and it's mimicked in the Congenital Heart Guidelines also. So if you have a prosthetic cardiac valve, you're considered high risk. If you had previous endocarditis, you're high risk for the rest of your life. And then the subset here is congenital heart disease. So if you have a cyanotic disease, including shunts or conduits, you're high risk. If you've had a completely repaired congenital heart defect, either by surgery or catheter intervention, so we're talking ASD closure in the cath lab, ASD closure, VSD, this kind of thing, and it's completely repaired with no residual lesion, it's reasonable to have antibiotics prophylaxis for the following 6 months. And this is while your body covers up those materials with your own body cells. And then finally, it's reasonable for, it's high risk if you've had repaired congenital heart disease, but you have a residual defect. You may have a small jet that's preventing endothelialization near that. And then also cardiac transplant patients who have cardiac valvulopathy. So except for these conditions, patients with congenital heart disease, antibiotic prophylaxis is no longer recommended. Pretty much the exact same information except from the Congenital Heart Guidelines instead of the infective endocarditis, listing the same things. So guidelines in medical guidelines are listed sort of class 1, class 2 with the amount of evidence. And for infective endocarditis, there's a couple of class 1 guidelines specific to congenital heart patients. And it's good stuff. So first of all, number one I start is that patients with congenital heart disease should be counseled on their risk and whether or not they need antibiotics. It shouldn't be a guessing game. One of your care providers should go over this information with you so you know when you're going to the dentist, do I need to take antibiotics? Do I not need to take antibiotics? If I'm having this surgery, what do I need to ask for? Patients that have the signs and symptoms of infective endocarditis, should be cared for by people that are familiar with patients with congenital heart disease who are familiar with infective endocarditis. That's the bottom part there. Because infective endocarditis in the surgical world, it can be very rapidly progressive. Here are the current recommendations for antibiotics. Most of us can take oral antibiotics, and it's a simple single dose of amoxicillin. If you have a penicillin allergy that was severe, there's alternatives. If you're unable to take oral medication and swallow pills, you can get them to mix it with the bubblegum flavor and you can drink it. Or there's IV and IM alternatives. So, and then for non-dental procedures, prophylaxis for non-dental procedures, like we talked about upper GI scoping or colonoscopy, isn't recommended in the absence of having an infection. And then there's some guidelines, class 3, which is sort of lower level guidelines. When it comes to patients who are having vaginal deliveries, if you have a prosthetic valve, or if you have unrepaired or cyanotic, it's reasonable to have antibiotic prophylaxis there. We typically don't give antibiotic prophylaxis during uncomplicated vaginal delivery. We do during C-sections typically. So in summary, these are the major changes to the endocarditis guidelines. And I just started a couple that just to emphasize that you're more likely to get bacteremia in your bloodstream from your normal daily things like brushing your teeth than you are during a dental procedure. Antibiotic prophylaxis may prevent a very, very small number of these cases. And then the conditions associated with congenital heart disease are pretty restrictive into who's we still recommend antibiotic prophylaxis for. And then the only other thing here is, which I found interesting, was that there's not really a whole lot of data on antibiotic prophylaxis for tattooing or body piercing, which was interesting to me because it's probably very low risk also. Thank you.